Good morning. So it is a pleasure to be here. I did note I got an extra 15 minutes. It can't be because of my charm. It has to be because of the topic and the impact on patients. I want to remind everybody that university hospitals and Case Western Reserve University has a long and important history in the stroke care under urgent circumstances for patients. The things that we have talked about here, that we do imaging, and that helps us to decide who we should take care of, we have been on the forefront of that since the mid-1990s. Intra-arterial therapy, and I will take you through that and its history that we now do on the right selected patients. We've been treating patients with intra-arterial therapy since 1995. We have seen its benefit. We have tried with the rest of the country and at times the world to figure out who is best able to benefit this. So it's a rich legacy, and let me show you some of that and how we take care of it. I'm going to take you through some definitions because there are some quantitative things we talk about here. I've laced in 3 different patient examples, and it's really important always to remember we're taking care of patients and to show you the kind of impact we can have. Then, as some of my colleagues have done, the history and how we got to the point of what our current recommendations are, another patient, and then our stroke guidelines. And I'll try to slow down when we get to that because that's the crux of what I want you to remember here today. And then we'll finish with the last patient. So let's talk about the modified Rankin scale. So this is our outcome measure. After all, when we're said and done and we've tried to take care of patients, we want to know how they did. And this is a crude scale in some sense, but a very effective one in others. It's only got 6 points on it. 0 is on the good side, and 6, as you can see, is very much not on the good side. What we care about is in that line typically between 2 and 3, because that's the line between dependence, I can't get through my day by myself, and independence. And that's the thing that almost all of us care about the most. Now, some people think there's a difference between 1 and 2 where you have some degradation in can you do all things. But for most purposes, when you're dealing with major stroke, the cutoff is can I be independent as opposed to dependent? And even those 3 and 4s are things we don't really like to see because now you're either having to have a caregiver or you're frankly bedridden. Now, on the other side, we've talked about when the patient shows up and how can we assess them in a simpler scale in the pre-hospital setting. But before we're going to do something like go inside somebody and directly challenge their cerebral vessels, we're going to have a much more sensitive way of measuring just how sick they are. And this is a 42-point stroke scale. As Dr. Sila pointed out, there's some insensitivities to it. But in general, it really helps us to idealize, is this a minor condition and maybe we shouldn't take all those full risks? Is this in the moderate range or are we really facing something severe and catastrophic? And stroke can be severe and catastrophic. So those are the scales. In your materials is tons of literature if you want to know more about it. It's widely accepted at this point, even if it is somewhat imperfect. So I'm the one who's going to talk about imaging today, and I'm not going to make you imaging specialists, but I'm going to try to give you a sense of how imaging impacts what we do in stroke. So this is a series of slices through the head by a CT scan, and there's those superimposed labels that say M1, M2, M3 on your screen, the upper 4 slices, the lower part of the brain, and then 4, 5, and 6 on the lower slices on the slide, the upper part of the brain. Those are dividing the middle cerebral artery, the largest distribution in our brains, into 6 areas. And then there's 4 smaller areas, which you probably can't see the labels well. One says I for insula, and another C for caudate, and L for lentiform nucleus, and IC for internal capsule. What they're asking the interpreter to do is to go to those 10 areas and identify whether we can see what is commonly called gray-white differentiation. If you look around the edges of that brain, there's a thin, brighter gray or white stripe, and then there's a darker gray underneath that. That represents our brain structure. We have our neurons, our cells on the outside, and those connecting structures, axons or white matter on the inside, and they look different on density scale, And that's gray white differentiation in a normal person. What we're trying to assess here, and in fact in all the imaging we're trying to assess, is just how damaged is that brain potentially when that patient presents. We've been talking about with my previous colleagues, how do we identify patients who are really having a stroke? And if they are, what are the criteria by which we could give them an intravenous drug? But now I want to know, is it worth going inside their body, which clearly has risks, and going up inside their vessels to salvage something? But just like in a heart attack, if that heart muscle is unfortunately committed to death, it cannot be saved. And it's the same for brain matter. So we want to know, is that brain at risk, but not yet committed to a cellular death, and so we can salvage it, or it has already crossed over no matter how bad the implication may be to that patient, and we have now entered a range of futile care. So that's part of what we're looking at. Inclusion and exclusion is always what we're doing. In medicine, we're always balancing the risk of what we may offer with the benefit. And here we're trying to do that layered on with imaging. Okay, patient number 1. So this is a single cut, same kind of idea we talked about before. This is all the patients I'm going to show are roughly the same age range. This is nearly 60 years old, a gentleman, right side weakness. They all have the same kind of clinical picture. Aphasia, so they're going to have a moderate to severe stroke scale, and less than 6 hours from onset. So they meet our timing criteria of could we intervene. So we see in that white cycle, inside that white circle, is a wavy area of white, right? That is density in the middle cerebral artery. Higher density than on the other side. You don't see that white squiggle on the other side because there's clot inside that MCA instead of flowing blood. And that clot is blocking the flow. That is a bad prognostic sign, right? We have now proven a large vessel occlusion. And we'll talk about that at length. And then some of those arrows show you, and this is a subtle one, I admit, but they do show you the area of the brain where that white stripe is less apparent than the other side. It's not as clear as the one I showed you before. It's a subtle one, but this is a relatively large area, even on the head CT, that suggests something severe is already happening and a large part of the brain may be irrevocably involved. And then the aspect score. How many areas would be involved? That's at least 2 on the lower part of the MCA. We've lost the insula, that's 3. We've also lost the lentiform nucleus and the internal capsule, that's 4 and 5. So we're down to an aspect score of 5. We're in the range of bad prognostication. But we're not quite sure, so we did further imaging. So this is a single picture from what we call a CT angiogram. Contrast is in the vessels, and you can see coming north, let's see if I can make this pointer work. Looks like I can. Contrast is the white, that's the top of the internal carotid arteries. The eyes are over here, the patient is looking at us. This is normal anterior cerebral arteries coming north in the middle of the picture. On the other side, a large branch middle cerebral artery coming off, and you can see it truncates on the left side. It just starts, and there is nothing up here. So, large vessel occlusion, left M1, or the first segment of the middle cerebral artery. Again, high-risk patient. What about that brain? Can we salvage that brain if we open that up? Well, we do further imaging, and what you see here is 4 panels. On your upper right is blood flow. Blue is not a good sign. Normal is the other side, that rich red and green color, that's normal flow. We have almost no flow. We also, therefore, have on the lower 2 panels almost no contrast getting there, reflective of what we put in the brain. So the transit time, or the time of arrival, is markedly delayed throughout that whole hemisphere. And then last in the upper left is the blood volume. And that's saying how much blood is pooled in that brain and very little. What that means, no matter how much I may wish it to be different, or that patient or that family, is that brain has crossed a barrier we can no longer fix. That patient is doomed to lose that part of the brain. And so there's no point in us trying to go in and open that artery. And we do take care of those patients as best we know how. We treat them with blood pressure. We have discussions with families, as you know. And in this case, to relieve the swelling of that brain. The bone was taken off on the left side, but a large infarct, all that darker gray on the left side of the brain, the right side of the screen. So this is a devastating situation. This is a malignant MCA syndrome. It is a bad disease. I want you to remember this, and I'll come back to it at the end. This is the bad side. This is the thing we're fighting with everything we're trying to bring to bear and avoid for our patients. Okay, stroke history. As Dr. Silas suggested on the IV side, this has been going on for a long time. 1980s, there were case reports, there were early trials. PROACT 1 put a catheter up next to the clot, used the agent that was available then, which was recombinant pro-urokinase, a thrombolytic enzyme to dissolve clot. You either put the catheter up and put the enzyme in, or you put saline in, so think about the ethics of that. But we stopped that in 1996, prior to enough data to gain approval, because the IV therapy came out and 43 patients were done and it looked promising, but the trial never went further. It was reestablished later as PROACT 2. Now, on the non-enzyme side, if you didn't get pro-urokinase, we thought we were being helpful. We gave heparin through the catheter. And we had improved clinical outcome by 15%. And this was a randomized controlled trial. So this is class 1 data. But the FDA at the time decided for this kind of disease, with this kind of intervention, at that state of culture, they had to have at least 2 trials before that they would approve intra-arterial therapy. So it was not an approved therapy. We continued to use it off-label for those patients who we thought made sense. The next major advance in intra-arterial therapy was the devices. First thing we had was catheters and dripping the enzyme directly on the clot. The next thing we had was the ability to bring a device into the artery to try to capture and extract that clot. The first thing out was something called a Mercy device. Think of it as a corkscrew sort of combined with an ice cream cone, so it had a narrow tip, and you would try to wrap that into the clot and then pull that thing out, and while pulling that out, also take out the clot, and by the way, not tear the artery. It was already in the market for retrieval of lost coils, for examples. It was a single-arm study when it first came out, not a definite benefit. Other devices followed. Penumbra is a company that's famed for its aspiration device, catheters specifically designed to go up and then have suction applied to try to pull out or attach to that catheter and extract clot. And most importantly in this field, 2 devices, Trevo and Solitaire, came out. These are stents, much like cardiac stents, much like stents we use inside neck and cerebral vessels when we have to. The difference was they come permanently attached to a wire. They're not designed to be left behind. They're designed to be popped open into the area of clot, left there for a certain number of minutes to try to get the clot to bind to it, and then when you extract that stent along the endothelium to try to get the clot to come out with you as well. Of importance, relative to that first device, as is often the case, the second generation was notably better, and I'll show you some of that data. However, this all led to 3 trials, and I'll share some of them with you in a minute, in 2013, all published historically in the single journal edition of the New England Journal of Medicine, all showing no clear benefit to intra-arterial therapy. Now I'm going to pause at this point and take you back in time. So we're in 2013. We've been taking care of 40 patients a year on intra-arterial therapy. We know we help certain patients. Other centers across the country know that. We've now done the best science knows how to do, randomized trials. Randomized trials show no benefit. Huh? Well, randomized trials aren't perfect, and I'll show you what happens next, but it's an important thing. Science, trials, what we learn is always an evolving thing, and I think the cardiac world has done that longer than the neurological world in running trial after trial, and a failed trial is something to learn to teach you what to do for hopefully the next preferred trial. And we all serve an academic mission, and one of that is so we can learn to be better tomorrow than we are today. So it's important when we treat our patients, we talk to our patients, why are we doing trials? We're not experimenting on anyone. We're not investigating them. We are trying to learn how to be better tomorrow than we are today without hurting you along the way. It is really important to remember that in the care of patients and the communications with families. So let me go on. The devices and the trials. This was Penumbra. It's the aspiration tool, 2009. Entry had to have a stroke scale greater than 8, so moderate or severe, within 8 hours. No IV therapy, or you had IV therapy and it didn't work. 125 patients. Pretty good recanalization. I don't have time to go into how the various ways we define recanalization, but no matter how you define it, 82% is remarkable. 4 out of 5 times it works. And here, for the first time, we started to see data that looked promising. 25% had that good outcome. Follow-up to that trial retrospectively looked at another 157 patients and now claimed nearly 90% recanalization rate and 40%. Not a randomized trial. Retrospective look subject to bias. Additional trials. 2012 Trevo 2, 80 patients treated compared to 90 with the Mercy. How did we know one was better than the other? And I can say that definitively now. This is one of the ways. How often do we recanalize? 86% versus 60%. The new device seems to be better, and it seems to hold at a data rather than anecdotal way. Solitaire, one of the other stents, Swift trial, 58 patients, 50 versus 55 with Mercy. And you can see here, dramatic difference in the technical ability to get that clot out of there and get flow back in that vessel. And not surprisingly, at least at a concept level, improved functional outcome and mortality at 90 days. Okay, the neutral trials. What was that time in 2013? IMS-3, stroke scale greater than 10, so you're now heading out of the moderate into the severe strokes. Received TPA within 3 hours, and then they had to get enrolled additionally, so time has gone on now. 40 minutes later, they're enrolled after TPA. In retrospect, it has a high stroke scale cutoff and a short time window. CTA, that picture I showed you that confirmed there was a large vessel occlusion, only done in half the patients. And in fact, when they went and did intervention, they found that only 20% of the patients had large vessel occlusion. So it wasn't in design, in retrospect, perhaps the best way to go. Mercy only approved at the device at the beginning. So remember, Mercy wasn't the best device. It was used 73% of the time. And then equivalent independent mortality and hemorrhage rates between whether you just got IV or you got IV, between mostly that and Mercy. Synthesis, expansion, and MR rescue, all were similar trials, had the same major problems. The major problems was did not confirm large vessel occlusion before trying to take care of the patient, and used a device that wasn't particularly good at achieving its technical goal of getting the clot out. People didn't give up. Other trials were started. Lessons were learned. And Mr. Clean, a remarkable name in retrospect again, now we let a wider range of patients in. Just because we said it was greater than 2 doesn't mean they all were, but we opened the window of who we could do. You had to be over 18, and now we didn't have to be within 3 hours, we had to be within 6 hours. So it's a greater pool of patients to work with. And here it was really unrestricted in terms of therapy other than intraarterial. Do the best you can in both arms. Best medical therapy, which includes IV if that's what you wanted to do, or add IA. So the only thing that was randomized here was the intraarterial therapy. 500 patients. Remember those earlier ones go all the way back to PROACT 2, 125, PROACT 1, 43, some of the earlier studies that didn't do. So this was a big trial, multinational. Stent retrievers were used, and technical success is where it needed to be to show benefit if it was going to be there at 82%. And we'll slow down on this here because it's one of the few slides I have with the dense data. So the lower control bar versus the upper intervention bar. The colors are that light blue. Probably I would have used a different color because that's over on the right. That's the worst outcome, right? That's death. The dark blue is over at the 0. You'll notice the only 3, but the only people who had total normal after this were in the treatment arm with intraarterial therapy. And if you look at those middle two, the ones and the twos, both the independent groups, there's a much larger number who are independent or totally normal if they were treated with intraarterial as the only added thing above everything else we knew to do. And really the shift there is getting people out of those 3s, 4s, and 5s and moving them over to the 1s and 2s and occasionally the 3. That's all the difference in the world. Go back to the beginning when I started with that modified Rankin scale. Those are the independents. Huge shift here. So look in the upper right where we summarize this. 33, a third of the patients in the interventional group were functionally independent at 3 months versus 20% in the best medical therapy arm. And what does that mean in terms of Dr. Sila's picture with how many we treat versus how many we get better? For every 3.5, it's pretty hard to draw half a person, so we say 3 to 4 people, 1 has benefit. There are very few therapies we use in medicine that have that kind of odds. And when this trial came up, the world paid attention. It's a hugely important trial. Now, those 3 points below, anything that we considered a secondary income. Did your image look better? You had less brain volume at infarct when we looked 90 days back? Yes. Were finer measures of clinical abilities improved? Yes. Was mortality equivalent? So one of the problems is, again, myself and my colleagues put things up inside people's heads, inside the arteries in their brain. There is considerable risk to that. But at 500 patients in a trial, was there any change in mortality? There was not. And the second most scary thing is intracranial hemorrhage of significance. No change in that either. And I can tell you, having done this since 1995, this was the first time we'd ever seen a trial where we didn't have those complications go up, so we had some risk that we had to counter with benefit. So this trial said we've got benefit and very little risk, even though it was highly aggressive. And then there were coincidentally 4 other trials. So just like there was this moment in the history of stroke care where 3 trials in a single journal edition said you can't do this, there were suddenly 5 trials going on that flipped it. So the MR Clean positive results had an effect on those other 4 trials for ethical reasons. And those data monitors went in and looked at their data prematurely because they now had a different ethical background. They had reason to believe there was randomized controlled data that said that this was already of benefit. So entering more patients, if your data already showed it, would not be ethical because half the people don't get the treatment. So interim analysis was done, and you can see the names of the trials and you can look them up. And every one of them had their enrollment cut at that point and were across the 5 of them from 6 hours, some of them all the way to 12 hours. So we've opened the window. That's the other message of these. So now we've combined, so what is the range of benefit and the range of risk amongst these trials? So amongst those 5 trials, after intraarterial endovascular treatment, you have 30 to 71%, rounded off at 50%, independence at 90 days versus 19 to 40, rounded at 25, so twice as many people are independent if you go through this effort. An absolute increase of 13 to 31%. So this was huge for this community and changed people's opinions. And my other point from Mr. Clean, what about the risk side? If the benefit side is so clear, the risk of symptomatic brain hemorrhage was 2 to 8%, only nominally increased over the medical side, so a 2% shift. If you're one of that 2%, that's important, but it is nominal given the risks going on. And the death risk was 9 to 20% after treatment versus 12 to 22, so no change there. And risk of a major adverse event, as you can see here, was essentially identical. So it reiterates now across 5 trials, much gain, little risk in a very dangerous situation. Just so you remember, there are risks no matter what we do. And there are risks beyond the major ones. These are the minor ones. Hematoma at the site, we can take care of that, but it is a problem when it happens, 2 to 11%. We're giving a lot of iodinated contrast so we can see the vessels, so some kidneys don't take to that well. Almost always that's a reversible problem, but not always. And then the rare things. Allergic reaction, pseudoaneurysm, that's where in our efforts to get in, we make a false connection between the artery and the vein. And then anywhere where we're on the inside of the vessel from the leg all the way up to the brain, we can damage that in the right patient or the wrong set of circumstances and cause a number of problems. Thankfully, they're rare. Infection and bleeding in the abdomen, bleeding in other places have all been really rare. Okay, that was getting dry, so another patient, if you will. Now we've shifted to MR instead of CT. So it looks a little different. This is a diffusion sequence. So this is the thing that's out there. It's one of the gold standards of seeing infarct, dead tissue. And here in that circle, you see sort of an S-shaped area of brightness that isn't seen on the other side and looks brighter than all the rest of the brain. And that's the only part of this person's insula or insular cortex that has infarcted at this time, even though they're a 63-year-old woman with right-sided weakness, aphasia, can't speak, less than 6 hours from onset. So just like our first patient, this is moderate or severe stroke symptoms. Now, instead of the CT scan showing us a lot of brain tissue already dead, where first view says, hey, not much dead tissue here. There's a lot maybe we could salvage. An important piece. And then this is an MR version of an MR angiogram as opposed to a CT angiogram. Same thing, we've pictured it so white is the flowing in the blood, and you see the two carotids coming up as you did before, and on the other side, we've got the middle cerebral artery coming up. On the other side, here's the middle cerebral, and right at the edge of the circle area, you see it truncates. You have the posterior circulation superimposed, so try to blank that out of your mind. But look at all this normal arterial flow on the right side of the brain, and all of it absent over here. That's why this patient's aphasic. That's why the right side of the body is weak, because we're not delivering blood to the left side of the brain. So M1, again, it's the first branch of the middle cerebral artery is occluded. Large vessel occlusion proven. Now here's the scary piece of the picture. So this is a time to peak map. This is asking if we put contrast in the blood and we can trace it coming in. Does it take longer to get there? Is that hypoperfused? Is there less blood to that part of the brain? Yeah, half the brain, as the MR angiogram suggested, isn't getting very much blood. And we know that neural tissue can only tolerate that for so much time. Absolute absence of oxygen, 3 minutes. Some things happening here to let some oxygen get to this tissue, or the brain would have already infarcted. It hasn't. Ideal candidate for us to try to open that up and salvage this brain. And so this person goes to angiography. And here's an angiogram. Now the catheter is in, and now it's black in the vessel instead of white, because that's what the iodinated contrast looks like. You can again see the carotid artery coming up. And we can see we took this picture right when the contrast was at the top of the carotid and going over towards the middle, and north is the anterior cerebral. And then here's that little stump of the middle cerebral artery. Now you can see better detail. You can see the impression, that white hump of clot blocking flow, and just a little bit of contrast getting off that horizontal segment and then stopping. You can also see, if you look to the top of the picture, some really thin branches trying to come from that anterior cerebral artery and come down and supply part of that brain that's not getting flow from below. And it's that combination of occlusion here and at least something that's coming over the top that's probably allowing this brain to survive at least this far, even though it's already symptomatic. It's that balance of things. And if there's no collateral supply and there's no blood at all, then you have the patient who, no matter how fast you try to take care of them, you can't, because the brain can't even stay along and be at risk. Okay, so no distal filling. We've got an at-risk brain that has not yet infarcted. What are we going to do? This treatment was started with the aspiration device. So now you see the same anatomy, but through it, this catheter, which is giving us that shadow, and it's coming up, and you can see the tip has a marker on it, and it's right next to that little indentation or hump of clot, and we're trying to aspirate, vacuum, pull, get that material out of there. 2 passes, we get it open, there's more flow distally, still partial occlusion, because if you look to the top, we're not filling in very well, and you still have incomplete filling in that horizontal segment. We now put a stent retriever in. This one is the Trevo. I don't know how well it shows back where you are, but you see this sort of interlaced metal material with the tip over here coming out of the catheter. That is the stent deployed, open, engaged with the clot, trying to smash it against the side, catch it in the tines of the metal, and let blood flow through all at the same time. And we leave that up 5 to 10 minutes, and then here it is with that up. So now you can see the contrast is flowing through. That stent is already helping deliver some blood to the brain for 5 or 10 minutes while we then try to get the clot out. And here you can see we've taken the stent out, and it's better, but it's not good. It's better because that proximal segment now fills. But we have this secondary clot that's moved distally and is blocking. And so we put an aspiration tool back in, put it more distally, started to pull that out again, and got even better flow. The net result, however, was that all took a lot of time, and some of the brain was not salvaged. And you can see that dark gray area that looks like a poorly defined lake up on the superior left side. That's infarct. What you can't see so well here, unfortunately, is that this part of the brain coming down on the left side looks like a little bit darker gray than over here, and that's because this tissue also is, unfortunately, at this time we didn't know whether it was just edematous or it wasn't going to make it. It doesn't make it, and this patient, despite all that, does not have a full improved outcome. They're better, but not normal. Okay, let me spend 10 minutes taking you through this and 5 minutes on the last patient. So this is our intra-arterial protocol, and we'll break it down. This is based on what we do at UH and what we do at university hospitals, and Case Western is based on our national guidelines. We don't just make this up. So we're not going to take you through all the pre-assessment. I think we've referred to some of that with Dr. Sila and on the pre-hospital side in the first talk. We do a CT scan without contrast. Why? We want to exclude blood and see if there's a big infarct. If there is blood, that's over on the right side of your picture, hemorrhagic stroke. That can go to neurosurgery. That can have an anticoagulation workup, but that's not the kind of stroke we're going to try to treat. Our protocol is if it is CT negative or there's evidence of ischemic stroke, then call us the brain attack team. That's the us here. Whether you're at Case Medical Center or you're at the periphery or you're not even in one of our hospitals. And then we go through the assessment for IV TPA, and we initiate that TPA if eligible, prior to doing anything else. We've learned, let's not delay, just go ahead and get that in, right? That's an important drug. What's next? So if we have the left side of your screen, everything's pointing towards intra-arterial therapy, that's the path we're going to take, and I'll talk through in just a second what does that everything mean. And on the right are all those kinds of things Dr. Sila talked about, which is the relative or absolute contraindications. We're not going to go forward. So what do we want? I call this the rule of sixes. We want our stroke scale to be at least 6. If it's not a bad enough stroke, we probably shouldn't be putting catheters inside your arteries next to your brain. We want to make sure that you don't have a large confirmed infarct that we can't salvage. So a measure of that is that aspect scale. We want you to be 6 or greater. Remember, 10 is normal. You should be getting TPA under IV circumstances and all the reasons, unless you're not eligible. We want to be able to prove, before we go arterially, that there's a persistent internal carotid or M1 occlusion. We want to make sure you weren't so disabled at baseline that we can't salvage you clinically. And we want to make sure that our time to groin, that's the third 6, is within 6 hours. So all the other things, we're not going to have the direct protocol for. So we might, if you're greater than 6 hours, use the DAWN trial. If you're disabled, we're going to think about that. If the core infarct is too big and you're too old, we're going to think about that. If you're just generally old, we're going to think about that. There's not an absolute exclusion, but like everything else, when you're old, you don't heal as well. You don't heal this as well. High INR, major comorbidities, all those sorts of things. Okay, the DAWN trial for a second, since I'm a promoter of trials. This is, you don't meet our criteria on time alone, and you have a major stroke greater than 10. So we're going to take you to advanced imaging. We're going to look to see that you had a decent baseline, so we can take you back to that if we're successful, and that you've failed or aren't any longer eligible for TPA. And the relative exclusions on the other side, what we're saying here is as you age, you can tolerate only so much infarct, and we have quantified measures of this in cc's. That comes down as the age goes up, or the stroke scale. Okay? So those are the ins and the outs. It's all printed and it's available to everybody on the Brain Attack team. Assessment with advanced imaging, we do that. We help people do that. We want to do that within 30 minutes. We want to do that by MR when we can, and we use CT as backup. There's all the usual ways to page us. Checklist for MR, ED, these are standard things we take everybody through. I don't think you need to go through how we do it. It's diffusion weighted and flare and MRAs, but we do have a standard sequence. We don't make this up every time, so we can iterate it faster. And then if we can't get to MR or the patient isn't MR safe, we use CT, as plenty of places do across the country who don't have MR at all. And then if everything else works well, we get informed consent. We want to be door to groin in 90 minutes, and that is a lot of moving parts to achieve, trust me. And then the things we measure so we can benchmark our success against the rest of the country and the world is time to catheter access and how well we did, how much flow there is when we're done. So that's the totality here. These are important things I want to tell you. We're in the age of lean training where we look at efficiencies. There are angio teams, there is nursing, there is imaging, there is transport, there is finding where is the patient's family in our complex set of buildings. There is, did the labs come back? There is, did the communication happen between neurology and the endovascular team? All of that, and by the way, physically get the patient on a table, get them prepped and draped and in comfort enough for us to work on them, and get that all done in 90 minutes. It's major effort, and we practice it, and we do it remarkably well. But it takes everybody, including those of you in here who are involved. Okay, patient number 3. 78-year-old woman, so this is the oldest of the 3 I've shown you. Right-sided weakness again, aphasia, less than 6 hours. So now we have the same sort of picture. One through the lower part of the brain, and within the circle, you can see it looks sort of medium gray, and I don't see that ribbon of white along the outer margin, and I'll be clear here for you what I mean by the outer margin within the Sylvian fissure here. Right here, that whole area looks uniformly gray, and out here you see this nice little curvy area that's brighter. So that's the normal gray-white, and it's lost here. But that's the only part of the brain in which that is lost. And so if we count those 10 areas and aspects, we get a score of 9. So that suggests, just like that MR diffusion case suggested, that there's only a small part of brain at infarct and potentially a large part of brain that we can salvage. So this patient meets our criteria to proceed. Now, is there really a large vessel occlusion? This is the third one I'm showing you, so you have some history in your mind, patterns. So this is the carotid coming up. You get the anterior cerebrals coming toward the middle. You get the middle cerebral on the other side coming across and feeding up. And just like the other two, this one fills about halfway through that first segment into the temporal branch coming off, and then it truncates again. And we have some collateral supply up here, but compared to the other side, there's a very little going on. Right? Confirmed large vessel occlusion, small part of the brain involved. Should we proceed? Yes. Advanced imaging again. Now, this is a CT perfusion study. I'm sorry I didn't catch it before. We've moved which one's in which corner, so I have to take you through that again. Blood flow in this case is in your lower left. And you can see it's that medium blue. There's disabled blood flow getting there compared to the other side. But the one next to it on the bottom is blood volume. And you can see there's some central area that's diminished, but that large area of dark blue that was in that first case, if you can remember that picture, that's not here anymore. So there's still volume in that tissue, and that's why the patient doesn't have infarct yet. There's still blood getting there. But is there deficit? There is. The blood flow is diminished, and you can see the time the blood getting there on the upper two pictures is markedly delayed. So we again have this potential penumbra that we can salvage, hypoperfusion, not yet committed to cellular death. So hibernating heart, we don't have that term in the brain, but this is at risk, potentially salvageable tissue. Perfect candidate. Catheter angiogram, you've seen one of these before. This is the black coming up towards the middle. You get all the normal anterior supply. You're also filling the posterior here, and it's busy, but you see this inverted hook coming down, and then it just stops. It's the middle cerebral artery. All of this tissue, everything on your upper left here is not absent brain. Sometimes the hardest thing we like to say when we're teaching imaging is the hardest thing to see is what's not there, right? You should see all these vessels here, nothing there. So that's why you have the hyperperfusion and the at-risk. So what did we do? We went up and we put one of our stent retrievers in. And you can see it comes down, we still have this occlusion, but there's another branch filling. And so now instead of absence up here, you have increased flow. But we haven't fixed it yet, we still have an occlusion. And after withdrew the stent, we had better flow. Coming down the hook, we now keep going farther down, we make the next bend. So each time we've done that, we've picked up more vessels that are now open. So there's a whole bunch more supply up here on the upper left. But there's still, right in here, now probably an M2 or an M3 branch, depends. Every time we make a branch, we give it another number, is still occluded. So we have one more thing to try to fix in this patient. So this is putting the stent retriever back up, leave it in for 5 more minutes, retract it again, and now this is the picture. And now this is nothing else to show you. It's normal anatomy. So we went from an occlusion to wide open. And I don't know if anybody gets to see Dan Simon talk about cardiac catheterization and saving patients. If you're a cerebral angiographer and you do endovascular stroke work, this is home run. Complete absence of flow to complete normal flow. And then I turn it back to clinical colleagues and hope that the patient's going to do extraordinarily well. You saw the second patient. We got nearly to this point. Took a long time. A lot of different catheters. Did okay, but not perfect. This patient, this is the home run patient. They're perfect. They're 0 on the stroke scale that has 42 points. They were at 19. 19 is a really devastated patient. So we changed this person's life. We selected the right patient. We did the right things. We had the skills. We also had the luck. So in sum, in my last 30 seconds, this is what it looks like in endovascular therapy. You have a very malignant disease. You have patients who lose half their brain, their quality of life, their independence. We can keep them alive, but we cannot make them better. You have those we attempt to help, and we help somewhat, but not all the time. And you have these patients on the right, where that brain is totally normal, and it would have been totally devastated if all of you and all of us and all those trials hadn't happened, let alone the engineers who came up with the devices that are game-changing. It's a wonderful world we live in. These are high odds and a lot of things we do. It's been a pleasure to talk to you, and I think my time is up.